Hello everybody and welcome to today's dementia presentation. My name is Ailish Mooney. I'm one of the clinical psychologists in Cheeverstown House, and today is kind of an introductory chat on dementia, what it is, what it looks like, and a couple of strategies to consider when you're working with people with intellectual disabilities in day or residential settings. So just a brief overview, dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairment or cognitive decline. There are lots of different types of dementia. The most common types found in the general population and with people with intellectual disabilities is Alzheimer's type dementia, which is probably the one you're most familiar with. And that occurs in about 50 to 75% of people. Vascular dementia, which occurs in about 20 to 30% of people. Lewy bodies dementia, which is about 10 to 25%. And frontotemporal dementia, about 10 to 15%. And dementia doesn't have to be just one type. There's also mixed type dementia where you might have both, let's say, vascular features and Alzheimer's features, or both frontotemporal and Alzheimer's. So, it can be mixed. In general, what we see in the disability population, or particularly the intellectual disability population, is Alzheimer's type dementia. And it is 3 to 4 times more common in older people with intellectual disabilities, in particular if the person has a diagnosis of Down syndrome. And the reason for that is the protein that causes dementia, essentially by building up and causing plaques on the brain, is on the 21st chromosome. And somebody without dementia has 2 copies of that chromosome, but somebody with Down syndrome has 3 copies of that chromosome. So because they have that extra copy of it, it means that they produce more of the protein that causes plaques to build up in the brain and dementia to develop. Some common issues in people with dementia include loss of short-term memory or confusion, increased fatigue, anxiety and fear. Pain is very common. Greater susceptibility to stress. So, things like you might have been okay in large crowds of people or in places with lots of noise before developing dementia, but after developing that can increase your confusion and can increase your stress levels. Loss of interest in previously preferred activities. Isolation, which might lead to depression, especially in the younger population. Inability to coordinate the movements of the body due to the communication pathways in the brain being damaged. So that obviously has an impact on your mobility. So if you can't coordinate, your legs to step up, to get up a step to the right height, then obviously you're going to have issues with increased falling and tripping. Nighttime and sleeping issues. So as dementia progresses, your sense of time tends to go a bit wonky, for want of a better word. And lots of people with dementia would, wake in the middle of the night, not entirely sure what time of day it is, that kind of thing. Hydration and nutrition issues are often present. Personal hygiene issues, so like refusing to shower or losing their independent skills around showering or toileting, where they need much more support. Incontinence, vision and hearing difficulties, communication difficulties. So changing behaviours, so somebody might act differently to how they used to act. They might develop epilepsy, or they might have a worsening of their epilepsy. They might have hypothyroidism or hypertension or diabetes. They might get regular lung or chest infections. They might also have heart disease, and that's particularly common in those with vascular dementia. They might get frequent UTIs, and then they might also get delirium due to infection. So it would be very common for the people we support who have Alzheimer's, if they got an infection, they might also develop delirium on top of that, which looks like a worsening of their Alzheimer's or their dementia. But when it happens suddenly and it's in conjunction with an infection, it's often something that is short term, and that once the infection clears up, that they return back down to their baseline. So I really like this image in terms of looking at the person's senses in relation to their dementia. So it's not just those previous symptoms that we're talking about, but actually your senses change as you kind of progress into dementia. So looking at the start of a person's sense of like touch. So they might have a dysregulated sense of temperature. They might not be able to tell the difference between feeling hot or feeling cold, or they might not feel things to the same amount in their mouth. So, you know, things like putting a spoon into your mouth triggers you to swallow something, where somebody with dementia might kind of lose some of that sense of touch in their mouth and may not respond the same way. Or, you know, just their general sense of touch, like not sure if they're holding a cup and all of a sudden opening their hands and dropping it. In terms of their vision, their eyesight may reduce, their lens can become cloudy, and their peripheral vision can become reduced. So that peripheral vision, being able to see to the side of what's going on around you, but also a reduction in visual spatial skills. So things like difficulty judging distance, depth, and the size of objects. So again, you see that when somebody's picking something up, or in particular when you're walking up and down stairs. So one of the things we often notice in the disability population is people become much more reliant on staff, you know, linking them, wanting to kind of lean on them, in particular when they're walking out and about where the ground is uneven or they might have to encounter steps. And that's often associated with changes in depth perception. Then when you look at taste changes, there's often a loss of sensation in the mouth, decreased number of taste receptors, and an increased preference for sweet over savoury foods. In terms of hearing, a person's ability to hear can often be affected, and their auditory memory and processing is often very significantly affected. So things like, you know, remembering a simple instruction, they might forget the instruction quite quickly. So we find that auditory processing reduces quicker than visual processing. So I mightn't remember an instruction you've told me, but if you've shown me something with it, I might have a better chance of remembering it. But it also impacts then on things like being able to follow a TV program, because if you've forgotten what's been said at the start of the conversation, you're not really going to be able to follow the storyline. And again, that's something that as somebody's dementia progresses, it gets worse with it. It's not something you might notice in the very early stages. And then finally, the sense of smell. It may reduce, and that is particularly important, obviously, when you're looking at eating, because, you know, smell can trigger our want to eat something. But also, if somebody lives more independently, their ability to check and see if a food is spoiled might be reduced. So moving on to kind of environmental considerations of supporting someone with dementia, we're going to look at sensory, physical, opportunity and safety aspects. So when you're looking at the sensory considerations, you are looking at things like lighting, the physical environment, supporting somebody's maybe depth perception with stairs, or the physical environment. You might be looking at kind of adaptations that need to be made, opportunity to engage in things, and safety elements. So tips for environment. So use soft lighting. Don't obstruct natural lighting if possible. So make sure the curtains are pulled back in the house, and ideally don't have very harsh lighting like fluorescent lighting, because it can create shadows and be difficult for people to see. Keep the floor a uniform colour with a matte finish or carpet finish. So shiny floors can create a reflective surface and can really mess with people's depth perception. It can be very difficult then for somebody to feel safe or secure when they're stepping across it. But also lots of changing floor textures. So if you're not really sure about what's happening or what that looks like, the changing textures can make people really struggle to get over a threshold from one floor type to another. So ideally what we recommend is keeping a uniform floor colour with a matte finish. Use bright stripes to signal transitions or breaks in rooms. So if you do have breaks in rooms, or you do have a threshold that somebody has to get over, rather than something that's really kind of blends into it, a bright stripe can help people notice that there's a change in the transition. Use photograph signage, so something as simple as putting people's pictures on their bedroom door so that they know what their bedroom is, or putting a photograph of the bathroom on the bathroom door so that they know that that's the bathroom door. Or even more kind of cleverly, I've seen done in lots of houses, where they put photographs of what's inside the presses on the presses. So if I'm getting confused and I don't know where the mugs are kept, and I open every press in the kitchen to find it, that's frustrating. But if there's photographs up of the things that I access more frequently on the outside of the cabinet, then I'm going to be able to see what's inside. And that, like, usually we would recommend things like, you know, clear doors on the cabinet so that they can see through. But this is one way to kind of, if you don't have clear doors, to overcome such barriers. Or the same thing, let's say, on the outside of your wardrobes or your set of drawers in your bedroom. Having a photograph on the outside of it can help. So be aware of smells and creating pleasant aromas, and that's particularly helpful for stimulating somebody's appetite. So, baking things in the house, having nice smells in the house can be really important to help people kind of have some calm, relaxation, but also to stimulate appetite, in particular around meal times. Consider the proximity of the bathroom. If you have somebody with dementia living in a house, you don't really want the bathroom to be at the other end of the house away from their bedroom, because they are going to need more frequent access to it. Set up the dining area in different ways depending on the meal. So, how you set up the table for breakfast versus dinner time might look different, and that will help the person orientate a little bit better to the time of day and what meal they're expecting. Leave plenty of space between the tables for wheelchairs, in particular for those with reduced mobility. So one of the things that's really challenging for people is if they have to kind of squeeze out by someone, especially if they're in shared housing, it can be really difficult for them to get up and leave when they want to, and it can make them feel a bit more trapped in those places. So the use of flowers or napkins on a table can really help kind of make the space more inviting for people, and also just kind of brightens the place up. And it has been found to kind of, I suppose, orientate people to like a dining space. So reducing surplus noise or distractions. I suppose that's kind of one where there's a little asterisk, because, obviously we want to reduce surplus noise, but the reality is there is going to be noise in houses and in day centres. But things like, if you're a staff member and you need to take a phone call, go into the office and close the door. So something small like just closing the door behind you to reduce the excess noise, the unnecessary noise. Or don't have a TV and a radio on in the space of 1 or 2 rooms. So it's just reducing that additional noise. Obviously there's going to be some noise, but sometimes I think we become a bit accustomed to just the additional noises, and we don't tend to notice them anymore. Using picture cards to offer choice, or using objects to offer choice. So one of the things that's really important to maintain somebody's independence as they age through with Alzheimer's and dementia is to continue offering them choices in ways that they can access. So if it's easier for somebody to pick through photographs, use photographs, it might be easier to pick through symbols. It might be easier to hold up 2 objects, like something as simple as offering somebody cereal in the morning. Do you want this cereal or this cereal? And showing them the box. So just, really making sure that you are considering how you're offering choices. And if that's something that you're not sure about, because maybe the person's communication styles or profiles might have changed, do contact our SLT colleagues. They're always happy to give advice and help around that. Use memory cues. So, things like fish and chips could be served in paper, in newspaper, something that kind of draws on somebody's childhood. So, scones on doilies, tea from china cups. So if you're looking back to, let's say, somebody who's in their 50s or 60s who we're supporting now, looking back to kind of when they were in their childhood about what were the commonly used things then, and then drawing on those commonly used things, because it's much easier for someone to access something that's in their long-term memory than their short-term memory. Continually encourage independence. Use a toast rack to stand toast upright so that they can grab it themselves without you having to place it on their plate. Provide modified utensils so that the person can continue to eat independently without being supported. So that might be something as simple as contacting our OT and SLT colleagues for kind of a modified spoon so the person can still, eat independently, or modified or weighted cups or plates. And then things like having a uniform tablecloth and coloured utensils, having the appropriate crockery. That, that's just around eating, but also encouraging somebody's independence in, let's say, showering. So they may not be able to shower independently completely on their own, but they very well might be able to hold a washcloth and do a small bit themselves. And it is so important to continually maintain that independence. So it mightn't necessarily be functional for the person to clean themselves, but the sense of independence of you doing a bit for yourself is so important. And it's so important to keep the brain firing, remembering those things as well. It allows somebody to maintain their dignity for that little bit longer. And then looking at seating plans. So if a person Are they sitting with the person they would want to sit with? If it was a previously fraught relationship, don't sit together. They might choose to sit alone, but they also might choose to sit beside somebody. So just looking at the person's layout in the house. So when we're looking at specific areas of the house and what we can do to kind of make it more dementia friendly, we'll start with the kitchen. So look at the physical aspect of the kitchen. Make sure it's clear, easily identifiable as a kitchen, that there are glass jars for tea and coffee so that you can see through to see the tea bags in one and the coffee in the other. Doing things like labelling the hot and cold water function on tap. So you might have, a bright red bit for the hot and the cold for cold, or the blue for cold. Looking at the sensory elements of the kitchen. So kitchen surfaces are often very reflective and shiny. That is not ideal. So things like using mats or tablecloths to reduce shiny surfaces can be really helpful, in particular when you're continuing to promote somebody's independence. So it might be very hard for somebody to make a sandwich on a shiny surface, but they might be much better able to do it on a matte surface. The smell of baking and cooking can encourage a person with dementia to eat. And then provide opportunities for independence. So ensure that everything a person is likely to use or need is within their reach and is easy to use. For example, if somebody needs to make a sandwich, you might set everything up on the counter for them so that it's easy to use, but then still encourage them to go through the process of making the sandwich independently. And then obviously consider the level of assistance required for safety. So if you need to use a restrictive practice for whatever reason, make sure that you're going through the restrictive practices committee. But ideally, we recommend that you're just with the person, doing things with them, not for them. So in as much as humanly possible, do with, not for. So just to go through those points a little bit more, we're going to look at a couple of pictures of what is dementia friendly and what isn't dementia friendly. So we're going to start with this first picture. So you can see that the space is quite cluttered. There are things all around. It's kind of hard to figure out what goes where. There's stuff all over the fridge. So in generally just too much overload of things in the kitchen. Now the positive parts of this is there are some see-through presses, but overall it's just far too cluttered. So in comparison, if you look at this, and I know it's not a photograph, it's a little bit harder to make out, but it is a dementia-friendly environment. So if you look at the countertop is clear, but the things that you are likely to need, like a cup and the kettle, are out. There is open presses or see-through presses that allow the person to be able to see what's inside of them. In terms of cooking material, things like the oil is maybe out on the counter. There's a cloth out on the counter. And in terms of the sink, you can clearly see there's a blue and a red bit on hot and cold taps. So you can see everything's very clear. Everything's very kind of accessible. So what you're looking for is not overloading the senses, not overly stimulating, but easily accessible. So moving on to the bedroom. So again, looking at the physical elements of the bedroom, ideally a contrasting bedroom door. So one of the things that we tend to do, in particular in kind of houses for people with disabilities, is we paint everything kind of greys or beiges. But it can be very hard for someone to distinguish the door versus the outside surround if the door is white and the walls are white. So what we are recommending is things like a contrasting colour of the bedroom door, and ideally personalise it. So you might have different colours for different people. You might use photographs of the room on front of it or photographs of the person on front of it. And one of the key things is ensuring they're at eye level. So often we put them at our eye level, but often people we support with Down syndrome are a little bit smaller than us. So making sure it's at the person's eye level, not our eye level. Use contrasting bed linen and sheets to help the person clearly identify the sleeping area. The bed should be visible from the toilet area so that the person, if they have to get up in the middle of the night, they can see the toilet. But also when they open the bathroom door, that they know they can go straight back to bed. Bed covers are often better in a colour that contrasts with the carpet so that it doesn't blend in. So if you have a grey carpet, you might have, green or red bed covers. And consider the bed type. So does the person need a high-low bed? Do they need more of a hospital type bed? Do they need a double bed because they like to sleep in the middle of it and like to have space around? So it's kind of looking at what their general needs are. Looking at their sensory elements of the bedroom. So does the area provide a sense of calm? I would say consider the need for mirrors. So as I mentioned briefly in some of the other slides, reflective surfaces are often difficult for someone with dementia. But when you're talking about mirrors, you add on the additional complexity of the person may not recognise themselves anymore. So they might remember themselves as a younger person. And now they're looking in the mirror and they're seeing, a much older person. They're not sure who it is. And it can be frightening. So if all of a sudden you see an image of someone you don't know who it is in your bedroom in the middle of the night, that can be really frightening. But at the same time, people often need mirrors to get ready and to brush their teeth and things like that. So it's not necessarily saying no mirrors. It's just maybe don't have them in a space where the person might accidentally walk past them and not know. So you might put them on like the inside of a wardrobe door rather than the outside of a door. Provide opportunities for independence. Does the person have easy access to their clothing? Can their wardrobe or drawers be left open or slightly askew as a prompt to let them know what's in there? Can you put photographs on the outside to let them know where their belongings are? Can you get clear covers? Those kind of things. I know for somebody recently we put in a rail and we added their most frequently used things in an open rail, and it really helped prompt them to be able to get dressed themselves. And then looking at the safety, so are there trip hazards? In particular looking at like dressing gowns hanging on the end of the floor, rugs, any clutter that is unnecessary, and paying particular attention in the transfers in and out of bed and on the way to the bathroom. So again, in pictorial form, looking at what kind of a dementia-friendly environment looks like. So if you look at the top left-hand picture, you can see what they've done is they've painted different colours around the bedroom and bathroom. And that indicates that you're going into different rooms. And then also look at the railings all along the wall to make it easy access for the person to get in. The floor colouring is the same colour all the way through. It might be different flooring, but it's the same colour. The wood laminate might be a bit shiny, but it depends on the person. There's easily, you can see the bed just inside the door. There's a chair at the far end, and the same with the bathroom. You can easily identify what it is from outside the door. And then looking at the bottom picture. So things like having photographs of friends and families on the wall, having a bed cover blue, different from the colour of the carpet, having the bed slightly turned down so the person doesn't have to struggle to get under the covers, having the bathroom door left open so that the person can clearly see that the bathroom is in there, having the person's clothes visible, especially their frequently used clothes, and having their self-grooming items there in the top of the dresser. You might have your hairbrush out, and you might have, if you wear jewellery or makeup or those kind of things out. And I don't know if you can kind of make it out, but actually the drawers that are in it have pictures at the front of what's in each drawer. So really looking at how to adapt it so that it is dementia friendly. So moving on to the bathroom. So you're looking at the physical elements, the safety, the ease of access. So adding things like grab rails, and usually contacting our OT colleagues is where you're going to find is most helpful here. So they're going to look at how the person accesses the toilet. Like, is it easy accessible? Do they need a shower chair? Do they need grab rails? Is there a step to get into the shower? Do they need it to be a flat surface? If they like baths, is there a way for them to easily get in and out of the baths? So they're going to look at all of those transfers. And then in terms of the sensory elements, looking at the flooring and the mirror glare, as we've mentioned briefly, looking at background noise and having familiar smells in the bathroom is going to be really helpful. Look at the visual contrast. So having a different coloured toilet seat to the rest of the bathroom can really help the person see where it is and identify it as a toilet seat. And I'm going to show you a picture in a minute. Provide opportunities for independence. So is there equipment that can support the person? Like label the taps, or you might have a toothbrush that the person can more easily use and independently do. You might have something that squeezes the toothpaste out without the person having to balance, the toothbrush in one hand and the toothpaste in another hand. Those kind of things. And in terms of the safety, can they find the toilet at night? Do they need sensor lights? So something as simple as having a sensor light at let's say at the bottom part of somebody's bedside locker. So when they get up, their feet hit the floor, the sensor light goes on, they can see where they're going. Having handrails, bath, shower seats, ensuring that the thermostat for the hot water is not set too high. Remove mats or trip hazards. Shower curtains might also pose a falls risk, so doors are better than curtains. And consider the suitability of door locks. So is it easy to open and close? So again, looking at some pictures of what that looks like. So you can see here the blue toilet seat contrasts significantly with the rest of the bathroom. The same with the shower chair and the grab rails. So another colour that's very frequently used in toilet seats is red. So having a red toilet seat. But it is very important to make sure that if the person is independent at getting up and down to the bathroom, that we are making these considerations and these adaptations as early as possible. So moving on to the sitting area or relaxation space, ensuring the physical area is calm, quiet, that's really essential, because you don't want a busy place if that's your relaxation space, if that's your place for sitting down. So can the person watch the road or look out in the garden, and do they have a comfortable place to sit? And in particular, remembering that as the person progresses through dementia, they do find it harder to watch television, watch movies. Now they might watch ones that, let's say, we have a lot of people in our service who would watch the same movie over and over and over again. They might be quite content continuing to watch those or having them on in the background. But I do think it's really important to have a space that looks out onto the world outside as well. Considering background noise, lighting and tactile opportunities. Providing opportunities for independence, like having a photo album or a life storybook in this area, can be really helpful to help the person look through the pictures, but also help them engage in conversation with people. So if you're sitting with them and you're trying to engage with them, taking out a life storybook and flicking through pictures of their past might just stimulate some conversation and really make the interaction more meaningful for the person. Having preferred activities that the person engages into and ensuring that you have all the necessary materials for that. And then ease of use for TV and radio. So you might move from a very complex set of controls to a very simple on, off, up or down button. And then safety. Remove any rugs, clutter and prompt a clear route from the door entry to the person's chair. And again, looking at what that would look like in pictorial format, so you can see the couch colour is very different colour to the rest of the room. It's set up in an area that looks outside into, the beautiful landscape there. We mightn't quite have that in Dublin, but still looking outside into a garden. They have flowers which give a sense of fragrance and colour to the space, makes the space quite relaxing. But you can also see there's no clutter, there's no rugs, but there is still pictures up on the wall. You still have those home comforts. So it's about making the place, really comfortable. Not to forget our garden and outdoor space, and that becomes more and more important, to be honest, as somebody ages, because if you're less able to get out into the community and do all the things you used to do before, so going to your coffee shops or going into Tesco or whatever it was, your garden becomes your haven. It becomes the only space outside of your house that you frequently use. So making it easy to find from the inside, having no furniture blocking the access to the garden, having seating available at several spots in the garden, so they don't have to go all the way to the back of the garden to sit down, that you might have just a couple of seats dotted around so somebody can sit at any point where they become tired, but also making sure that it's wheelchair accessible. If the person is using a wheelchair or a rollator or a walker to get around, making sure that the paths are accessible for that. In terms of the sensory elements, looking at the colour of the flowers in the garden, maybe including something like a bird table or a bird bath, or having additional garden features like, water features, that you might have the sound of water trickling in the background, making sure that there's lots of really lovely scent in the garden. So it's really important to consider the sensory elements of the garden, but also ensuring that you have areas of brightness and areas of shade. So if the garden is a very sunny spot, ensuring that there is shade so that the person is protected. Providing opportunities for independence, so access, to be able to the person to access it easily from the inside. Visual prompts to engage in gardening tasks. You might have the watering can for somebody to water, but also things like raised beds, so that the person might be able to easily, pull a few weeds or, pick some herbs, plant some vegetables, but the person really does need to be able to access it at a physical level in order to engage in that. And then safety. So making sure it's level access, that there's seating along the path, that there's no trip hazards in the garden. So again, raised beds can really help with that. And gardening doesn't have to be super expensive. There is lots of programs out and about that are up and running in terms of improving people's gardening. But get people involved in it, get them helping out, because it really is such a lovely, lovely element to do. So again, looking at a pictorial element of what a really dementia-friendly raised garden looks like. So you can see these curved paths make it very easy for the person to walk around. There's no level changes, there's no steps. There's lots of seating, so there's seating just outside the door. There's seating all the way around the path to make it easy for the person to engage. There's lots of kind of flowers with, I think I see kind of lavenders there with very strong sense of smell. There's a water feature there, the sound of trickling water. There's both shaded and sunny areas, and also just over here on the left there's a raised bed with vegetables in it to help promote the person to engage in the gardening tasks. But even if they're not able to engage in gardening tasks, the simple element of being able to sit in a garden surrounded by nature with beautiful smells and beautiful sounds can really help the person get a sense of calm and enjoyment. So we're going to move on to eating and drinking. So this becomes a particular issue often with people with dementia, in particular with people with dementia and disabilities. It's often one of the earlier features we see, and they have increased needs around their eating and drinking. They can also be at more risk of choking and aspiration. And one of the things we commonly see in people with dementia and disabilities is an increase in aspiration. So what I would say before I say anything else is to contact the speech and language therapy department immediately with any concerns. If you think that somebody is aspirating, please get a GP referral to the SLT department as soon as possible. Why is it important that we're kind of focusing on eating and drinking a little bit here? And I suppose there's lots of elements, but one of them being weight loss can cause the disease to progress more rapidly. So if somebody is losing weight quickly, it really can impact the cognitive changes quite significantly. Reduced food intake increases the risk of somebody's falls. So obviously if they're not eating enough, they're becoming a bit weaker, a bit faint, it's going to impact their mobility, their infections, pressure sores and increased risk of fractures. So it really does impact their overall well-being quite significantly. And then not drinking enough fluid can cause incontinence or certainly worsen incontinence, constipation, tiredness, reduced oral health, increased falls, cognitive ability. Dehydration is a significant risk if the person isn't drinking enough fluid. So some simple tips to increase food intake, and I would say that if this is something that you are struggling with people you support who do have dementia, do contact the adult MDT to look for an additional training. Our SLT colleagues can do a specific training on eating and drinking with dementia. This is kind of just general tips, so it's not going into as much detail as they would do. But general tips, looking at the presentation of the food. Does it look appetizing? Does it look appealing? Because there's nothing worse than something that's very beige and bland looking. It really doesn't encourage the person to eat it. Increase the person's physical exercise, because if they're not moving enough, they're not going to want to eat the same amount. So small things like walking, dancing, swaying to music, simple stretching exercises, chair-based exercises. It doesn't have to be anything major, just small bits of increased movement during the day can really help. Support the person to join in making the meal. So something as simple as laying out the cutlery, clearing away dirty dishes, facilitating with making the food, like peeling, washing vegetables, even something as simple as just putting a bit of salt in the meal actively engages the person in the cooking process. So I suppose one of the things we often do is we tend to cook the meals for people if they struggle to engage in preparation. And a small thing like just adding salt or pepper, or pouring something from one thing to the other, or even just putting one piece across can make a huge difference in the person's engagement in preparation of making the food, and even just being cognizant all of a sudden of, oh, food is being made. So that can stimulate the appetite. If you know it's being made, you start to think about food, and within half an hour or so you're starting to feel a bit more hungry. Having food little and often can be really helpful. So rather than sitting down to big meals, having small frequent meals can be a lot easier for the person to tolerate. increase the flavours, so moving away from those kind of blander foods to more spicy, herbaceous food, and combining fats and sugars. So Parmesan soy sauce are particularly good for those things. But even things like, adding butter to something, sweetening something up, can be really helpful to kind of prompt the person to want to eat. Regularly change the menu, because we all get bored of the same foods over and over again. So make sure that you're changing up the menu to offer the person choices. Rotate between different food pieces during the meal. So, a bit of meat, a bit of veg, a bit of potato, or a bit of pasta, a bit of rice, that you're rotating so they're not eating all of the one thing. And that, I suppose, is particularly important, that if the person fills up quite quickly, that they've had a range of foods to meet their nutritional value. Whereas if they eat all the meat first, then they might lose out on the nutritional value of the vegetables. Having teamed meal times can be a really fun way to liven up meal times and to increase food intake. It's things like, having afternoon tea, having dancing lunches. You might do a Paddy's Day theme or a cultural theme like an Italian night or a Mexican night, or birthdays, making a big deal about birthday meals, birthday cake, those kind of things. Growing fruit and vegetable and herbs, so in particular naturally sweet tasting foods like turnip, carrots, tomatoes, and bringing them from garden to plate can be a really, really helpful way to encourage somebody to eat. Going to different places like pubs, cafes, tea rooms, garden centres, etc. Baking and dessert making, so stirring mixtures, doing something as simple as an Eton mess, so a bit of meringue, bit of fresh cream, bit of fruit, or a fruit salad. Check when the person wants to have their main meal. So they might have always had their main meal at 6 o'clock in the evening, but they might be finding that it's easier to digest, or they want it more now in the middle of the day. So kind of moving around that suits the person. And actually, as people age, they do tend to want to have their main meal more in the afternoon than in the evening. It can be that a bit easier for them to digest. And then use of finger foods. So it particularly benefits people of arthritis who find it hard to use cutlery, or people who don't recognise cutlery, but they also might want to continue to feed themselves. So having simple finger foods can be really helpful with this. Now, little caveat to say that obviously you need to make sure that the person's eating and drinking guidelines are being followed. So if somebody's on a smooth, pure diet, you're not going to offer them finger foods of like crunchy carrots to eat. It does have to be in line with their guidelines as well. So if the person can tolerate finger foods, some tips for finger foods are: use foods that are easy to hold, use thumb-sized portions, use moist foods that aren't too dry, serve them at room temperature because the cold can put off, have a variety of different foods on the plate so the person can choose what, it mightn't be that they're not hungry, it might just be that they don't want that texture. So having a couple of different textures for the person to choose from is really helpful. Try and make the finger food colourful and appealing. Provide wipes and napkins for them to wipe their hands. And then again, check their dysphagia guidelines. Big asterisks there. Make sure that you are not giving them foods that are not in line with their eating and drinking guidelines. So why are people with disabilities at risk of weight loss or dehydration? So they often don't say if they're hungry or thirsty, and they often can't even identify it, in particular as their dementia progresses. So they mightn't feel hungry or thirsty, so they have to be prompted to eat and drink. They often have increased dysphagia needs, so changes to their swallow. They might spit food, or they might hold food in their mouth rather than swallowing it down. They might have poor oral care, so that can result in, oral thrush. It can result in, cavities that make it difficult to eat. They may not have teeth, which obviously affects their ability to digest food and to break it down. They might have a lack of interest in food, reduced concentration, in particular difficulties sitting for periods of time, which is why little and often is often more helpful than, big meals. Difficulty identifying food, difficulty identifying and using cutlery, changes to the person's independence and coordination abilities, and changes to their food preference, so again preferring sweet to savoury foods, or they might have an increase in paranoia around food. So not sure what it is. Is this going to hurt me? Is this going to be something that's harmful? Will this make me sick? So looking at signs of dehydration. So if the skin is dry, the eyes are dry, they might be confused or sluggish, lightheaded, faint with standing, or have dark urine. They're all very simple signs of dehydration. But really, if somebody has dementia, you should be keeping just general fluid charts, just to make sure that the person is drinking enough. Tips to increase fluid intake. So water served in small jugs, half filled, so that the person can pour it out themselves. Use ice to chill the water. Use dilutables for variety, so any cordials. I think we tend to go to the MyWaddies, but there's some really gorgeous cordials out there now, like elderflower cordial, or berries and rhubarb, or whatever it is. So using different varieties of dilutables for the person to see which is their preference. Hot drinks to be served from teapots with the teapot cozy, and again, those are the memory cues of their childhood. That's what they would have been much more familiar with in the earlier days, and it can give the prompt that this is tea, to drink it. Offer things like smoothies, milkshakes and ice pops to increase their fluid intake. Think of foods with high water contents like cucumber, melon and jelly. And offer milk. It's often tooth friendly and has lots of nutrients. So in particular, if the person isn't maybe eating very well, but they are drinking well, things like milk and fortified drinks can be really helpful. So just briefly switching over then to mobility and depth perception changes. It's more of an awareness. There isn't a huge amount we can do to support the person, bar contacting kind of our clinical colleagues around in physio and occupational therapy for aids and supports, but be very aware of difficulties walking down the stairs, difficulties getting on and off a bus, in particular if the steps are high. They might lean more on staff because they might kind of have a loss of their core control, and they might have balance difficulties. So if you notice any changes in the person's mobility, do contact the adult multidisciplinary team. Continue to fill in their falls forms to make sure that they aren't at risk of fall, and if they are at risk of fall, that the fall support planning meetings go ahead. So simple tips for communication with somebody with dementia. So introduce yourself. Don't assume the person remembers you, in particular if you maybe haven't seen them in a few days, or if you don't always work with the person. So just something as simple at the start of the shift, you might say something like, let's say you're working with a lady called Mary who has dementia. I might say, "Hiya Mary, Ailish here, just let me know if you need anything for the day." Something as simple as that. But just reminding them of who you are can be really helpful. Before you help someone, say what you're going to do before you do it. In particular, if you're going to touch them for, intimate care or feeding, just tell them what you're going to do before you do it so that they're not as startled by it. Talk through everything you are doing. Speak clearly and in a relaxed pace. If appropriate, you might hold the person's hand, you might say their name, and you might speak to them. So again, if I'm sitting talking to Mary, I might give Mary a tap on the hand. I might say, "Hi Mary, how are you? Will we have a look through your life story book?" And then talking through them. Talking about meal times when they were a child, so wartime rationing, childhood food favourites, growing food when they're a child, eating as a family, their role during mealtime can be really helpful, because mealtimes are so powerful for people that it's something that they really remember. Use short phrases. So don't use, if you can, we particularly, I think in this country, tend to fill with language. So, instead of saying something short, simply and clearly, we'll kind of say it in a roundabout way that might be 3 or 4 sentences long. So be cautious not to use too many words even. Say the person's name, in particular if you want to get their attention. Don't offer too many choices. So 2 or 3 choices is probably all the person is going to be able to manage. And allow the person time to think and respond to you. So just give them a couple of seconds, a little bit of time to think about their answer and respond to you. Smile. Something as simple as that visual cue can be really helpful for the person, in particular if they think that they're being given out to. So you might be saying something like, no, we'll just wait for dinner now, it'll be ready in 5 minutes. But if that is done without a smile, it might feel reprimanding. But if you do it with a smile, they might mightn't understand exactly what you're saying, but they are going to understand the tone and the gestures of how it's said. And be mindful of your language. Don't talk about things that are not relevant in that moment to the person or around them. So making sure that when you are communicating around the person or to the person, you're keeping it in the moment and relevant to the person. So looking at meaningful activities, use the Using Your Environment tool to determine what area of the person's life they want to spend time and energy on. So, looking at meaningful engagement, if somebody's 61 with middle stage dementia and an intellectual disability, they mightn't be that interested in going to day services anymore. They might much prefer to spend their time at home doing activities that are really meaningful for them. And rather than having to be up at 8 o'clock and on the bus before 9 to get out to day service, they might prefer to have a sleep in the morning, get up and they're ready, and then have the energy to do activities. Create goals and break them down into achievable steps. So rather than having this overarching goal of Mary's going to go on holidays to a hotel, breaking that down. That might be the ultimate goal, but how is Mary going to get there? Can you go online and look at things? Can you pick it out? Can you talk to family members? So breaking down the steps so that you have SMART goals. So specific, measurable, achievable, realistic and timely. So that you have a timeline on it. They're not goals that are just open-ended that are never going to happen. Look at the person's day service and job. Do they want to move to semi-retirement? And then looking at some life reminiscence work, creating a life storybook, looking at photo albums, music from the person's childhood, movies from their childhood, and use technology. Have it on like an iPad or things like that. I'm going to put a little caveat here. If the person may have had like a traumatic childhood where they don't have a huge amount of contact with family members, obviously, you're not going to create a childhood storybook with people that are not involved in the person's life. So, having things that are important and nice for the person in it. So really making it person-centred. Having low arousal environments. So speak calmly and slowly. Don't have excess noise. Don't have the TV on in one room, the radio on in another, and the staff on the phone in the third. Have calm living spaces and outdoor spaces. Look at the person's sleep hygiene routines. Are they in a sleep-friendly environment? So, no screens before bed, no caffeine, too late, or caffeine in moderation. Have a routine for getting to bed that you do the same thing every night. So I go to my room, I put on my pajamas, I brush my teeth, I wash my face, I brush my hair, I read a book and I go to bed. Have blackout blinds so that the light doesn't wake the person. And you might have alarm clocks that have day and night on them, or they might speak, and that can help the person orient themselves to time of day and night, in particular if they wake up in the middle of the night. And just some tips to maintain overall well-being. Have regular GP checkups or consultant checkups if required, like if they've epilepsy or diabetes or something. Have a constipation and elimination monitoring chart. Monitor the person's pain with the appropriate tool. Record their vital signs for any signs of infection. Maintain fluid input and output charts. Have eyesight and hearing tests yearly. And that's particularly important in the early stages of dementia because hearing loss can contribute to a worsening of their dementia. Monitor any signs of depression and support with therapeutic interventions as required. Ensure the person has the correct footwear and chiropody where required. Reassurance and a consistent approach as agreed by all of the team supporting them. So they're going to need lots of reassurance, but there is no point if you support the person in one way and another staff member supports them in a completely different way. That is going to be so confusing. So the whole team need to be on the same page about how you deal and approach with what approach you take with the person, how you deal with any particular issues that they're having. Knowing the person and including them in all aspects of his or her care. So nothing about me without me is so important. Don't assume that just because we know we know the person, we've been caring them for so long that we know everything about them. It's so important to make sure that the person is involved in their care. Consider alternative therapies if the person enjoyed the same in the past. So you might be looking at reflexology or massage or aromatherapy. So if they enjoyed something like that in the past, consider reintroducing it. Maintain independent living skills as much as possible, as long as possible. So if the person's struggling to do something, don't all of a sudden go in and do it for them. Do it with them so that they can do as much of it as independently as they can. Look at the environmental changes we've spoken about already. Look at an exercise routine that supports the person's, walking with no apparent purpose can be difficult for someone, but walking to the shop to get something might be easy for them. Encourage a healthy weight and diet, but obviously the person's choice is still respected and is still absolutely 100% their choice. Ensure good sleep hygiene routine, and then appropriate transport and OT requirements. So comment around pain and illness. So be very beware of confusing dementia with delirium. Often we'll get phone calls in the psychology department to say, God, somebody's dementia has gotten really, much worse in the past couple of weeks. We can't figure out what's going on. And it's often an onset of delirium because of an infection. So if the onset of the confusion or the change is abrupt, if it fluctuates depending on the time of day, if it lasts from hours to weeks, if their attention is impaired or disrupted, if they're kind of disorientated, not really that alert, agitated, maybe incoherent, disorganized or delusional or having hallucinations, then you're much more likely looking at delirium. So if the onset's quick and if it's very dramatic, you're probably talking delirium. Dementia, the onset is slow. So, slow decline over months to years. There's no huge changes overnight. So just be very cautious of that. So completing the baseline pain assessment tool is so important to be able to identify pain and illness in people. So the intellectual disabilities and dementia pain scale is the one that we would recommend. And then you also have the stop and watch to be able to identify illness. So common causes of pain including joint pain, UTIs, gums and teeth pain, constipation, impacted earwax, eye infection, cellulitis and arthritis. Signs of pain, there's loads, and knowing the person will usually help you kind of figure out what their signs of pain are. But common ones are shouting, pacing, being withdrawn, hitting out, nighttime waking, difficulty eating, screaming, crying, aggression, confusion, knees pulled up to the chest, heavy breathing, fidgeting, and so many more. But just being aware of the person's common signs of pain is really important to be able to identify any pain issues. Tools that are commonly used, in particular in Cheeverstown, dysphagia assessments. You have to contact the speech and language therapy department if you have concerns in relation to that. The must scores around weight management, food diaries, fluid charts, the Bristol stool chart. There's no agreed measure for dehydration, but keep track of the intake and output if required. Pain assessments, as I mentioned, the intellectual disability and dementia pain scale. The NTG EDSD just monitors their deterioration of dementia. Fall support plans, personal care support plans, meaningful activities and goal setting, community participation and sleep charts. So that's a particularly good reference for some further information. And thank you all very much for listening. If you do have any follow-up questions, please do contact the Adult Multidisciplinary Team for more support. You can find the Adult MDT referral form on the CT Library. The referral meetings are held every fortnight where new referrals are discussed, and they can be sent in either via email to the Adult MDT or via the post box in the clinic team meeting. Or feel free to contact the MHID team if the person is under their care and you have any concerns around deteriorating mental health. Thank you very much for listening.